Welcome back. Today we will discuss internationally comparable quality indicators of cervical cancer screening. Again, my name is Miriam Elfström and I work at the Department of Laboratory Medicine as well as the Regional Cancer Center of Stockholm, Gotland. I thought I would begin today's lecture with a picture of cervical cancer incidence and mortality in Europe. And there's a significant variation, as you can see. And the darker colors in both graphs are higher incidence and mortality, respectively, and the lighter colors are lower. And you can see that there are areas with quite high incidence here and areas with lower incidence. And the same thing goes for mortality. So why is this the case? Well, today we will be discussing quality indicators, that they should be associated with program effectiveness, and that the same calculation of indicators should be possible across regions and countries. And to do this, we will discuss why we need comparable indicators, what indicators should be prioritized, and then how indicators are used in practice. And here I have examples from several different sources, from our National Screening Registry, from the NordScreen project, and then from the European Union screening reports. And then I thought I would close with how new indicators are developed to give a sense of what lies ahead. So to give a bit of context on why we need comparable indicators, I think it's important to highlight that despite effective screening methods, implemented screening programs, and comprehensive EU guidelines, there's still this large variation that we saw in the maps of incidence and mortality across Europe. There have been a series of studies that have collected estimates on indicators across Europe, and different quality indicators have been used in these studies, and the results were different. So these studies included the UNIS report, the PREDICT report, and then finally the European Union screening reports that came out just a year ago. The indicators that we use should reflect program effectiveness, and they should be associated with improved outcomes. And I think the open reporting of indicators should also be prioritized, that this should be an ongoing process and indicators should be internationally recognized and mutually understandable. They should highlight performance against recommendations, and they should also highlight trends over time. So with that, I'd like to go into what we mean by quality assurance in cervical screening, so that we start with the same definition. Quality assurance consists of the management and coordination of the program throughout all levels of the screening process. This means the invitation that we send to individuals to participate in screening. It means the testing that we do. It means the diagnosis and clinical follow-up of screen positives, ensuring that there are ways for women to attend follow-up close to them, that they understand where to go next, and that they're invited even for that piece of the screening process. The aim of quality assurance is to ensure that the program performs adequately and that it provides services that are effective and in line with program standards. Quality indicators are quantifiable measures of the screening process and effect, and they allow us to monitor and evaluate the program effectiveness. They are the tools that we use to know if we are doing the right things in the right order and in the right time. So what indicators should be prioritized then? First and foremost, we need to think about who is being screened and what were the results. So we need to think about the proportion of the target population that attends screening. So are we reaching our target population? And then we think about the distribution of diagnoses. What results are coming from the program? How many women are HPV positive? How many of those women have cytological abnormalities, for example? And then we need to think about the follow-up of these test-positive women. Do they come for repeat testing, or do they need to be referred to colposcopy, for example? And there we need to think about how many are attending this follow-up test, because the effectiveness of the program lies in our ability to identify lesions early and to treat them so they do not progress on to invasive cervical cancer cases. And then we also need to think about the incidence and mortality of the disease that we're screening for. We need to look at the incidence of mortality over time to see if we are having an impact on these measures, because that's the ultimate definition of a successful program, if we can reduce the mortality related to the disease and if we can even reduce the incidence. So why is measuring program quality so difficult? Well, first and foremost, the definition of quality indicators are sometimes unclear. How to measure them and how to interpret them. And by this I mean who to include in the numerator, who to include in the denominator, whether you should include opportunistic screening, organized screening, etc., etc. And this can look quite different across screening settings. And sometimes people aren't even asked to measure quality indicators. So there may be quality indicators defined, but nobody has received the mandate to collect the data and to measure them. And sometimes data to enable assessing quality may not be available, because this requires population-based individual data that's accessible. And that's not always the case in all healthcare systems. This data may not be updated, or they may not be complete, or they may only include a subset of the population. So some guidance on prioritization and calculation of indicators. Indicators are outlined in the EU guidelines for quality assurance and cervical cancer screening. These are from 2008, and they're available online if you Google the title, and they're available on IARC's website. And there were updates in 2015, and these updates reflected the recommendation to switch from HPV-based screening, or to HPV-based screening. Many countries publish their own indicators. They use the EU guidelines as a base, but then they look at their own situation. In Sweden, there are 11 indicators outlined by the National Board of Health and Welfare. And the National Board of Health and Welfare has even published a longer document that outlines exactly how the calculation should be done and what are the desired levels where applicable. So what level of the indicator we should strive to achieve in our screening program. And these instructions for calculating that are produced by our National Board of Health and Welfare here in Sweden describe the purpose of an indicator, so you know how to prioritize it and what it will give you for information. It gives you a technical description of the calculation, so what goes in the numerator, what goes in the denominator, what time frame you should be thinking about, etc. And then it also describes the data that you need, where the sources are for that data, and how it should be collected. There's even a note on possible errors to be mindful of, or pitfalls in calculating it or interpreting it. And then it outlines the level of reporting. So if the indicator should be reported at the national level, or if it's most adapted for regional level reporting. So how are these indicators then used in practice? Well, first I wanted to give a sense of how we use them at the Swedish Cervical Screening Registry. And here you can go in to our website, actually, and all of the information is translated into English, and you can look through our data over the years if you like. The NKCX aims to provide an evidence base for incremental improvements of the cervical cancer screening program, and it does this through continuous reporting of the quality and impact of prevention efforts in Sweden. And the indicators that we highlight are the proportion of women who receive their invitation in time. And this is the proportion also of the population that is invited. And this is important to make sure that we're reaching everybody and that we're reaching them in the intervals that we say are most effective. We also measure screening coverage, so the proportion of the population being tested. And we do this by region and also by age to see if there are differences across the country or differences within age groups. We look at the diagnosis profile, and this means the distribution of screening test results. So in other words, the proportion of tests that are positive. And this is dependent on the quality of SNOMED codes. These are the diagnosis codes that are used, that are reported by labs. And this has to do with our ability to translate them or the lab's use of the national nomenclature. We look at the follow-up of test positives, so the proportion of test positives that are followed up that receive a colposcopy within a certain time frame, because we know that it's important that the follow-up occurs shortly after the diagnosis, and that we then can make a decision on whether that woman needs to be treated for her precancerous lesion or not. And then we look at the incidence and mortality of cervical cancer, and we do this by region. And this is to detect trends over time. So a couple examples of the graphs that we use. This is the coverage of Sweden, of cervical screening in Sweden, and this is for the years 2002 here on the x-axis to 2016. And this is divided by age class. So here we have the coverage on the y-axis, and then we have 5-year age groups, or 10 years, 5 and 10-year age groups here. And what we can see is in this dotted line, the gray dotted line in the middle, this is for the whole screening target population. And then we have the youngest women here that are attending and invited for the first time. And we see that their coverage is increasing over time. We have the oldest women here in the diamonds, and that has remained high and relatively stable over time. There's also a slight trend upwards here for the women that are 26 to 30 in the green. Another thing that we monitor, as I said, is the diagnosis profile. And here we have 4 different graphs of diagnoses. And here we're looking from 2007 to 2013. And you can see, for example, that ASCUS, atypical squamous cells of undetermined significance, has increased. This diagnosis has increased over time, as well as mild dysplasia, SIN1 or ELSO. We see relatively stable rates, perhaps a slight increase for severe dysplasia, and a somewhat smaller increase for moderate dysplasia. Other measures, inadequate smears, is relatively stable over time. There's a slight increase here. And you can look more closely into the other diagnoses if you're interested. But this gives us a sense over time of what the diagnosis profile looks like and the burden of disease in our population. So that was just a quick summary of what we have in NKCX. Now we're going to move into the NordScreen project. And this is a project that looks at the standardized and entirely open monitoring of quality indicators of cancer screening programs. And the countries included are in blue here on the map. So what are the aims of the NordScreen project? First, it's a pilot model for cross-country comparison of cancer screening indicators. As we mentioned previously, there's a need for standardization so that we make sure that we're understanding each other and that we're measuring the same thing in each of our countries. It's publicly available. It's an interactive web-based application, and this delivers cancer screening information and is updated annually so that we have information ongoing and aren't so don't need to rely so much on publications. It's built on standardized evidence-based monitoring of performance and outcome indicators. And it's based on the screening registry data from the Nordic countries, so from Denmark, Finland, Iceland, Norway, and Sweden, and we have also included Estonia. And it's an open service that can be used by anybody. So you can go into the website yourself after the lecture and check different indicators and programs in different countries and the coverage, what it looks like over time, for example. We hope that it'll be used by researchers, policymakers, journalists, and others that are interested in prevention efforts. So why is it needed then? Benchmarking of screening performance between countries is essential. This is to assess which results are feasible and also to allow exchanges of experiences so that we can share best practices between countries and improve our programs in that way. The comparison of screening performance and outcome of cancer screening between countries is currently difficult, as we mentioned at the beginning, and is partially been a challenge in many previous publications. And this is because survey data is prone to variable definitions and calculations between countries. And they also become rapidly outdated. So we may have to find it or collected information at a certain year, but programs change over time and the data produced are different. So standardized and publicly available information has the potential to stimulate collaborative research and quality improvement in screening. And this can then ultimately translate into improved health outcomes and improved effect of our screening programs. So the first indicator that's included in the NordScreen project is test coverage of the population. And we included this first because there's a solid link to screening effectiveness. As I said in the beginning, we need to ensure that the indicators that we use are meaningful for the outcomes that we want to see in our program. The definition and calculation have been standardized, and the same extraction scripts are used in all countries to ensure that the data are the same. The numerator is the number of women with a cytology or HPV test registered within a specified time frame, and the denominator is the number of women in the population by the end of the index year. And then you as the user in the system can specify if the indicator is presented by the country, by age group, by calendar year, or by coverage interval, depending on what you're interested in examining. So this is a screenshot of what an analysis can look like. Here we're comparing Sweden, Iceland, Norway, and Finland. And we're looking at cervical test coverage in the ages 30 to 59. And we're looking at test coverage in 5.5 years of follow-up. And you can see that it's from 1991 all the way to 2016 for Iceland, and then the other countries come in a bit later. So I encourage you to go in and look at these data and think about how you could use these to measure program operations and also to compare between settings. Another example of how indicators have been used and comparisons between countries is the European Union screening reports. And this report measures the status of implementation of screening programs. This is the second report here that I've highlighted, where you can see the cover. And this second report aimed to update and expand the scope of the first report. It collects more information on programs and further details on the indicators. And it looks at the status and organization of population-based cancer screening programs. So not just cervical cancer, but also breast and colorectal cancer screening programs. The data were collected in an aggregate form from countries in order to then estimate selected indicators of program quality. And these indicators were the indicators used in the European guidelines. And the data were collected using a web-based data collection platform. And the tables in this report look like this. They're by country here. And then for some countries, they're even divided up into regions. Here you can see for Italy, North, Center, and South. And then to standardize across countries, we've looked at screening coverage here for 30 to 59. But since recommendations differ across countries, we've also included all ages here. Now, as you will notice, there's a definition here at the top on what the numerator and denominator were. And then there's also quite a few notes here at the bottom. And I think this highlights the complexity of measuring indicators across Europe, given different settings, given different implementation strategies, and different program structures, and even different recommendations in different countries with regard to age and interval and test used, etc. On this next slide, you can see very small text, so it's a bit hard to see exactly what is measured, but this highlights the level of detail that they sought to achieve in the European Union screening reports. Again, it's reported by country, And here, these are program details. So this describes how the cervical screening program is organized. It describes the general information, so the ages, the screening interval, whether the program is population-based or not. It also describes the program organization, the funding sources, whether it's insurance-based or publicly funded, whether individuals have to pay for the screening test. And then finally, there's a section here on invitations for the screening program, how they are sent, whether they're sent to individuals or if they're reminders or if they include a fixed appointment, for example. All of that level of detail to give us a sense of how countries have implemented their programs and whether they're in line within the European guidelines. And again, at the bottom here, you can see that there are quite a lot of footnotes, once again highlighting that programs are different and that decisions are different across Europe. So then, how do we strengthen quality assurance? One way is through auditing of cervical cancer cases and control. And this can be done both in the laboratory setting, and this assures the quality of the testing, and then also within the screening program. And there you take all the cases in the country and look at different aspects of the program. You can also strengthen through monitoring and evaluation, and through repeated evaluation. I think that is particularly important. There's evidence from the HPV LabNet proficiency panels that shows that the performance of labs is improving. You can go in and read more about that at hpvcenter.se. I think the active annual systematic reporting allows for comparisons over time and program area identification. There's a substantial evidence base for implementation and quality assurance in Europe, but there's also a continued need for program monitoring and evaluation and for information sharing across borders. By reporting in this way, we can see how programs change over time, and we can also look to each other to see how we can strengthen our programs and see if there are best practices in another country that we could use in our own setting. So with that said, I'd like to conclude by saying that quality indicators are critical for ensuring that screening programs achieve the health gains that evidence has shown to be possible, and that comparisons across regions and countries required to clarify definitions and to encourage improvements. Thank you so much for your attention, and again, as always, email me if you have further questions.